Hello and welcome back to the CNS Pharmacology Masterclass. In this class, we will talk about all the medications that work on the central nervous system of the human body, and this video is going to be about the morphine. In this video, we will talk about a lot of topics about the morphine. You can always skip to other parts of the video using the video chapters available in the video description down below. For the people who don't know me, my name is Mustafa. I'm a medical doctor and I started creating lectures on YouTube since 2018. You can support my work by liking this video, and if you want to support more, you can by subscribing to the channel and subscribing to the Patreon, link provided in the description of this video. So let's start with an overview of the morphine. So the morphine is the prototypical opioid. The opioids are classified as analgesic drugs, and the morphine is derived from the opium plant, which is shown in this picture. And when you cut down this part of the opium plant, it gives you this material, which is the material that the morphine is isolated from. And the first time it is isolated was in 1803. And the name morphine is derived from Morphos, which is the Greek god of dreams. Now let's talk about where the morphine exactly sits with relation to other opioids available. So the opioids are classified into natural, semi-synthetic, and synthetic. The natural on two families, the phenanthrines and the benzyl isoquinoline. The phenanthrines being the morphine, which is our topic of discussion, the codeine and the thebaine, and the benzyl isoquinoline are the papaverine and the noscabine. The benzyl isoquinoline being having less effect on the central nervous system, so they don't work as analgesics as with other opioids. So they don't work as analgesics. The papaverine work as a smooth muscle relaxant, where the noscabine work as anti-cough medication. Now the semi-synthetic opioids like the heroin, the hydromorphone, the hydrocodone, the oxycodone, and so on, and the synthetic opioids which are classified into agonist, antagonist, and mixed agonist-antagonist, which also called the partial agonist. Now it is valuable to mention that both of the natural and the semi-synthetic opioids are agonist. All of them are agonist, and the synthetic ones we have all types. So the agonist being the mipridine family, the methadone family, and the tramadol. The antagonist being the naloxone and the naltrexone, and the partial agonist or the mixed agonist antagonist being the nalorphine, the nalbuphine, the pentazocine, butorphanol, and buprenorphine. So from that we understand that the morphine is from the phenanthrines, which are natural opioids. Now let's talk about the pharmacokinetics of the morphine. So it is available as oral, intravenous, intramuscular, and subcutaneous formulas. It has good oral absorption. The bioavailability after oral administration is 25% due to significant first pass effects, because when the patient takes the morphine gets absorbed from the GIT tract and goes through the portal vein and into the liver, where the liver will metabolize 75% through the first pass effect and leaves 25% to be active in the circulation. Regarding distribution, the morphine quickly leaves the blood and into the tissues, mainly the brain, lungs, liver, kidneys, and spleen. Morphine half-life is 4 to 5 hours, and it is metabolized in the liver by conjugation into active and inactive metabolites, and it is excreted 90% through the kidneys and 10% through the bile. Now let's talk about the morphine mechanism of action. Some of the information mentioned here is similar to the information in the first video about the opioid pharmacology. If you already hear about it, you can skip to other parts using the video chapters. So the morphine works on the opioid receptors, which are three major receptors, the mu, the delta, and the kappa. And each of these receptors has subtypes. The mu has mu1 and mu2, the delta, delta1 and delta2, the kappa is kappa1, kappa2, and kappa3. And all of these receptors are G protein coupled receptors. And these receptors all located everywhere in the body, including the brain, the spinal cord, especially the dorsal horn of the spinal cord, and the peripheral tissues. This is a cross-section of the spinal cord, and the gray matter is in the center, and there is the posterior horn in the gray matter, the lateral horn, and the anterior horn. The posterior horn is where the sensory information is coming to when it reaches the spinal cord, and here we have a high density of the opioid receptors. So when we give a patient an opioid agonist drug, so it would block the pain sensation coming from the sensory nerves. So morphine binds to these receptors and act as agonist on those receptors. The morphine exhibit a greater affinity to the mu receptors. Now let's talk about the morphine pharmacologic effects. So activation of these opioid receptors by morphine lead to several central effects and peripheral effects. The central effect, those are the central nervous system effects, and they include the analgesia, the euphoria, sedation, respiratory depression, cough suppression, meiosis, and nausea, and vomiting, and pruritus. And we will talk about each of them separately next. The peripheral effects include the cardiovascular system, the GIT system effect, respiratory system effects, renal, endocrine, and immune system effects, and also will be explained next. So let's start by talking about the morphine analgesia. So it is dose-dependent type of analgesia. The patient stay conscious and can locate the source of the pain. And morphine analgesia is sensory and emotional, so it relieves the sensory pain and the emotional pain. So the patient pain improves if it was due to physical problem or if it was psychological. And the morphine achieves analgesia through 4 different mechanisms. The first one being is that the morphine works on the opioid receptors, mu, kappa, and delta, in the posterior horn of the spinal cord, as we mentioned before, and those receptors are located in high densities in the posterior horn, and once activated, we decrease the release of substance P, which lead to decrease the pain sensation, and this is called spinal analgesia. So the first mechanism is the spinal analgesia by activating the opioid receptors in the spinal cord. Morphine also works by activating the opioid receptors in the brain, which once activated there, it would activate the descending inhibitory pain control pathways, which also lead to decrease the pain sensation, and this is called the supraspinal analgesia. So the second mechanism is the supraspinal analgesia, and this is by activating the opioid receptors in the brain. The third mechanism is that the morphine decrease the norepinephrine release in the CNS, and this lead to decrease the psychological pain. And the fourth mechanism is through that morphine also work on the peripheral opioid receptors in the painful tissue. The second central nervous system effect is the euphoria. This is a pleasant sensation with decreased anxiety, and people seek this effect during recreational use of this drug, and it results from decreasing the norepinephrine release in some CNS areas. The other CNS effect is the sedation. This is decreased consciousness, the patient becomes drowsy, and it is associated with some amnesia, so the patient would not remember some of these situations happened during when the drug was active in their bodies. And sometimes the patient sleep, but the patient can be easily aroused in comparison with the sedative hypnotics drugs, which may result in deep sleep. Sedative hypnotics like the benzodiazepines, they would result in deep sleep in comparison with the opioids. Now let's talk about the respiratory depression. This is the most important effect that you have to know about because it might kill the patient. All the opioid agonists, including the morphine, lead to respiratory depression by inhibiting the respiratory center in the brain stem. The respiratory depression is dose dependent, and when there would be a respiratory depression, there would be slower respiratory rate, which leads to CO2 retention. The CO2 can't get out of the body now. It is trapped inside the body, which leads to CO2 retention, occurs with cerebral vasodilatation because the CO2 would lead to vasodilatation and increase the intracerebral pressure. Respiratory depression is worse with patients with asthma, COPD, and head trauma, and that is one of the reasons why the opioids are contraindicated in people with these diseases. Cough suppression is another effect of morphine use. So morphine suppresses cough, and it may lead to accumulation of respiratory secretions and atelectasis. The other effect of morphine is the meiosis. It is constriction of the pupils occur with all opioid agonists due to vagal stimulation. Because of these, opioid agonists lead to vagal stimulation, so this would produce meiosis. Meiosis is when the pupil size is less than 2 millimeters, like this example here. It is mediated by parasympathetic pathway, which can be blocked by the atropine. And severe meiosis is indicative of toxic doses. So if the patient took a toxic dose of morphine, they would be present with pinpoint pupil, which is severe meiosis. And meiosis is a fixed feature in all morphine addicts. Nausea and vomiting is another effect of the morphine use. It occurs due to activation of chemoreceptor trigger zone, which give us the nausea and vomiting. Temperature changes occur with morphine use because the endogenous opioid peptides partially regulate the body temperature through their action on the mu receptors. So the endogenous peptides like the endorphins and the enkephalins, they work on the mu receptors to regulate the body temperature. And when we use an exogenous opioid like morphine, which also work on the mu receptors, this will affect the body temperature too, and the morphine produces hyperthermia. Morphine also aggravates itching. Itching is also known as pruritus. So the morphine effect decreases the pain, but not the itching, because itching has its own receptors, which are different from the pain receptors. And the mechanism of pruritus is through the peripheral release of histamine and central activation of proreceptive neural circuits. Now let's talk about the cardiovascular system. So the morphine leads to bradycardia due to vagal stimulation, and hypotension may occur with opioid use if there is some pathology in the CVS system, and histamine release occur with opioid agonist use like the morphine. It always occurs, so it would aid in the development of hypotension. So the vagal stimulation and the histamine release would both lead to hypotension if there is some pathology in the CVS system. In the respiratory system, morphine leads to bronchoconstriction due to vagal stimulation, because as we mentioned before, the morphine leads to vagal stimulation, and also bronchoconstriction occurs because of the histamine release, and the morphine also works on the mu and delta receptors in the bronchi, leading to bronchoconstriction. And because morphine causes bronchoconstriction, and remember that it also causes respiratory depression, that is why it is contraindicated in asthma, in COPD patients too. Regarding the GIT tract, the opioid receptors exist in high densities in the GIT, and when activation lead to decreased stomach motility and increase the tone, hydrochloric acid secretion is decreased. Small intestine tone increased with periodic spasms. The amplitude of the non-propulsive contraction is decreased. So in the stomach and in the small intestine, the tone increased in both of them, and the passage of the food is decreased. The same happened to the large intestine. So the propulsive peristaltic waves is decreased and the tone is increased, which lead to delayed passage of feces and allows more absorption of water, which ultimately lead to constipation. Constipation is a major problem in opioid use for cancer pain. So the pruritus now and the constipation, those are the most annoying problems in opioid use. This can be advantageous in diarrhea treatment. There is opioids that are modified to not cross the blood-brain barrier, so they work on the GIT only to treat diarrhea like the loperamide. Regarding the biliary tract, there is contraction of biliary smooth muscles, which give us biliary colic, and contraction of sphincter of Oddi lead to reflux of the biliary and pancreatic secretions. So both the biliary smooth muscles would contract and the sphincter will also contract, and this would lead to entrapping the biliary and pancreatic secretions inside. Regarding the urinary system, there would be immune receptors activation in the kidney, and the central nervous system have antidiuretic effect and lead to decreased renal function. So when the immune receptors are activated in the kidney, they would decrease the renal function and they would ultimately lead to antidiuretic effect through retention of water inside the body. Urethral and bladder tone are increased and sphincter tones also increased, which may lead to urinary retention, especially in post-operative patients. Also, in patients with benign prostatic hyperplasia, urethral and bladder tone increase and sphincter tones increased. This would also might lead to urinary retention and some obstructive urinary symptoms. Urethral colic could become worse when using an opioid as a pain control, because remember, the ureter is contracting when using the morphine drug. Regarding the uterus, the morphine decreases uterine contractions, which lead to prolongation of labor if the morphine is given to a woman during labor. Regarding the endocrine system, morphine stimulates the release of ADH, which is antidiuretic hormone, which lead to increased the water retention. It also increases the release of prolactin, somatotropin, and inhibits the luteinizing hormone secretion, and this leads to decrease the testosterone in men, which subsequently decrease the libido, energy, and mood in men. In women, because of these changes, this leads to dysmenorrhea and amenorrhea. Regarding the immune system, the natural killer cells and the lymphocyte proliferation is inhibited by opioids, so this would decrease the immunity and allows infection to become worse and allows tumor progression in cancer patients. And the mechanisms for immune system weakness are complicated. Now let's talk about the therapeutic uses for morphine. So it is used as analgesic for severe pain, especially acute myocardial infarction, cancer, and surgery. So the morphine is also used for acute pulmonary edema. So in acute pulmonary edema, the patient is anxious, hardly breathing, they are in severe distress, they are almost dying, so they feel really anxious, and the morphine works to relieve the stress and anxiety of this patient and to relieve the sensory and emotional pain. And it would also lead to venodilatation because of the histamine release, which lead to decrease the vascular resistance and the preload and afterload, and subsequently decrease pulmonary congestion. And it would also decrease the tachypnea caused by the CNS response to hypoxemia due to its inhibitory effect on the respiratory center, and this makes the patient relaxed. Morphine is also used in anesthesia as an adjuvant to the anesthetic agent, and it is used in regional anesthesia, in spinal and epidural anesthesia. It is also used in severe colicky pain with atropine because morphine is spasmogenic. It would aggravate the colicky pain that is coming from the spasm, and atropine is a spasmolytic, so atropine would reverse the spasm. Now let's talk about the adverse effects of morphine use. Regarding the respiratory system, there would be bronchoconstriction, which make it contraindicated in asthmatic patients, as we mentioned before. The cardiovascular system, there would be postural hypotension and bradycardia. And regarding smooth muscles, there would be constipation, urgency with difficult micturition, because morphine works on the bladder tone to increase it, to work on the bladder sphincters to also increase the tone there, and this would lead to difficult micturition and urgency. And it leads to gallbladder spasm and prolongation of labor, as we mentioned before. Another adverse effect for morphine is the morphine tolerance. This is a very important topic. So morphine tolerance occurs with repeated doses of morphine. Because the body would adapt to the morphine, there is a neuroadaptation to the morphine, and there is also receptor upregulation of the opioid receptors, so their number would increase, and this would lead to diminishing analgesic effects, meaning when you use the same dose that you used yesterday, this dose today would give us less effect because of the neuroadaptation and receptor upregulation that I mentioned before. And because of that, the patient has to increase the dose to get the same effect. And every opioid drug leads to tolerance, but in different period of time. The morphine generally take 2 days for the tolerance to develop. Tolerance develops to the analgesia, to the sedation, to the respiratory depression of the opioid agonists. It also develops to the antidiuretic, nausea and vomiting, and constipation effects. It is possible to produce respiratory depression in 60 milligrams of morphine dose in non-tolerant person. So if we take 60 milligrams of morphine and give it to a person who never took morphine in their life, they would have respiratory depression with that dose, while respiratory depression may not develop after administration of 2000 milligrams of morphine in 3 hours in tolerant person. Tolerance is difficult to predict. It depends on the effect, the drug, the time, and the individual genetics. And cross tolerance is common. The patient is tolerant to morphine would have less effects in analgesic response to other opioids, but it is still, when changing the opioid, there would be much better effect at the same equivalent dose. And that's why there is something called the opioid rotation. This means changing the opioid drug used every period of time to prevent tolerance. And it is used in patients with cancer and chronic pain. Changing opioids would have a much better analgesia to this patient at a lower equivalent dose. Another adverse effect for the morphine use is the morphine dependence, and it is on two types, the physical dependence and the psychological dependence. And let's start by talking about the physical dependence to morphine. So when there is failure of continuing administration of morphine, result in withdrawal syndrome. So because the body has adapted to morphine, when we stop the morphine, suddenly this would give us the withdrawal syndrome. Withdrawal syndrome present as rhinorrhea, lacrimation, chills, hyperventilation, anxiety, hyperthermia, mydriasis, muscular aches, vomiting, and hostility. And severity of these symptoms depend on the degree of the physical dependence the patient has. Physical dependence to morphine can occur within 24 to 48 hours if the drug is given every 4 hours to the patient. And the morphine withdrawal signs start after 6 hours of the last dose, because the half-life for morphine is 6 hours, and the peak withdrawal signs are seen at 48 hours and gradually subsides within 5 days. Administration of naloxone to morphine-dependent person can give explosive type of withdrawal syndrome, which occur within 3 minutes. So if the patient is dependent to morphine, don't give them naloxone, because this would give us explosive type of withdrawal syndrome, and it is quite dangerous. Administration of mixed agonist-antagonist drugs also precipitates withdrawal syndrome, but it is lesser in severity than when administering a full antagonist drug like naloxone. The other type of dependence is the psychological dependence. It is more commonly known as the addiction, which is morphine addiction. It is a chronic disease of the brain that affects reward, motivation, and memory. There is dysfunction in these circuits, leads to biologic, psychological, and social manifestations. Morphine addiction and opioid addiction in general is characterized by inability to impairment in behavioral control, cravings, diminished recognition of problems, and dysfunctional emotional responses. Finally, let's talk about the contraindications to morphine use. The head injury and increased intracerebral pressure, because the morphine causes respiratory depression, and CO2 retention, which causes vasodilatation in the cerebral circulation and exacerbates the increase in ICP. It is also contraindicated in bronchial asthma because of bronchoconstriction, and it is also contraindicated in patients with hypovolemia, hypotension, and bradycardia because it leads to vagal stimulation, so morphine can't be used in these patients. The better option is the mipridine because it doesn't cause vagal stimulation. It is also contraindicated in biliary colic and gallstones because it causes contraction in the biliary smooth muscles, and it also leads to spasm of sphincter of Oddi, which aggravate the colic. Morphine is also contraindicated in benign prostatic hyperplasia because the morphine increases the detrusor muscle tone with the spasm of the internal urethral sphincter, which leads to feeling of urgency with difficult micturition in these patients. And they already have difficult micturition, so this would also aggravate the problem for them, and it might lead to urine retention. It is also contraindicated in hepatic damage because the morphine is metabolized by the liver, and the morphine increases the risk of hepatic encephalopathy because it stays longer in the blood now because it can't be metabolized, and it might lead to hepatic encephalopathy. It is contraindicated in undiagnosed acute abdominal pain because morphine masks the pain and delay diagnosis, and it is contraindicated in infants and geriatrics because they are more susceptible to respiratory depression. And with that, we reach the end of this video. Thank you guys for watching. Please make sure to like and subscribe, and see you in the next video. Peace.